Okay, let's talk just a little bit about methods of data acquisition. In general, what we're talking about is localizer scanning. Maybe we'll address axial scanning, which is an older form of scanning that we still use for some kind of procedures now, and then the bulk of what we do is helical. Okay. And I want to point out that when we're talking about data acquisition, what we're talking about is the times when the X-ray tube is actually energized and the detector array is actually receiving information. It may or may not be spinning, right? For the localizer scans, it is not, the tube and the detector array are stationary, right? And we are doing this, it's just like an AP and a lateral, and so we call that, what's the word for it? They call them scouts, but the principle behind it is, so the philosophy behind this is a stereotactic approach to doing things. Stereotactic is just a fancy word for we're going to get an AP and we're going to get a lateral, and between those two views we are able to see 3 dimensions and we can plan accordingly, right? So between these two views, that's the word stereo, we can plan tactic, right? So most CT scans begin with at least one, often 2 localizer images where the tube is stationary, the detector array is stationary. We'll scan, we'll get like an AP or a PA, and then we'll move and we'll scan and we'll get like a lateral view. And then we'll plan off of that AP and lateral view. We call those localizers or scouts. I think some things call them scanograms. Different vendors are going to have different names for it. And so the position of the tube and the detector array will determine what we're visualizing. And it's important, one of the reasons we do this, again, one of the reasons we think stereotactically before we do a CT scan is if this patient lies outside of the scan field of view, right, the SFOV, in any direction, then we may not be able to visualize all the anatomy we're trying to see. So for example, if the patient is positioned too close to one of the ends of the scan table, right, we may not be able to go all the distance along the z-axis that we would want. If they're positioned too far to the right or the left, right, we may need to center them or we'll clip anatomy on one of the sides. If we have not centered the patient up and down in the gantry, then we may clip like the front or the back of the patient's anatomy. And so we miscentering, not only will it represent possibly a limitation in the information that we see, it can create artifacts. And now that we're doing more fancy stuff with the reconstruction side, if we do not get accurate scout images, the way it reconstructs will be weird. It may increase the patient's dose and increase errors in the way that it creates the images. Okay? So if we were to break CT scanning down to 3 steps, right, it would be data acquisition, image reconstruction, and image display. Right? So far we've talked about image display and image reconstruction. Now today we're just focusing on that data acquisition phase. Okay. Optimally, a localizer scan will include all the anatomy that it needs to be scanned, right? Every now and then we can plan outside of the area that's localized. It's a little bit like planning in the dark, but if for whatever reason the localizer didn't completely cover the anatomy to be scanned, we can initiate a scan that goes outside of the area of the localizer. It takes a little bit of monkeying around, but you can do it. And the big thing is just to make sure that the patient's appropriately centered. And then as we are starting to initiate these localizer scans, we're going to make sure that the way the patient is oriented on the table is correctly inputted into the machine. Most protocols already have a patient orientation that's preset in the CT control console. So when I initiate, like for example, a CT chest, it knows that the patient is head first and supine on the scan table, right? If for whatever reason I needed to, like say the patient came from ICU and I needed to flip that around so that they're going feet first in supine, I will need to flip. There's a little guy in GE, he's called Tom. It's like a little naked man on a table. I need to flip Tom around, right? So that it indicates that Tom's being scanned feet first, right? If I don't do that, everything's going to be wrong. The images will be mislabeled. The scan directions are going to be off. I'll wind up scanning the patient's eyes when I was trying to scan down towards their thighs. Problems like that, right? So everything will be mislabeled. All of the parameters will be off. Nevertheless, we can input that information fairly easily, and it's just a matter of clicking the mouse to rotate the little guy around. You can position your patient however you want on the scan table, however is best for that patient, but we just need to indicate that in the computer. Once we've got the localizer scans and we're looking at them, we actually use them to plan how the CT scan will be executed. So we can draw boxes on the localizer scan, and that's going to be the area that the CT scanner will scan. We can set our display field of view on the localizer scan images. And so the length of it, the width of it, the up and down orientation of it, all of those things are actually plotted out on these localizer images. So she mentions again, this is going to allow us to select an optimal display field of view. Do y'all remember what I talked about in terms of like what is an optimal display field of view for most of what we do? What do we want to make sure to include within the scan?
Region of interest.
The region of interest, good. That's a good way to put it, or the volume of interest, a VOI, a volume of interest. And particularly one of the things that I think is helpful 99.9% of the time is skin margin. If I can visualize the patient's skin margin, then I know, okay, if I'm scanning an abdomen, there's not a hernia outside of the area that I've got on these pictures. Or if I'm looking at a cancer patient, there's not an axillary lymph node that's inflamed that's outside of the area that I'm scanning. So skin margin is helpful. So, here's a review question. And we can't, let me try to move the slide over. Yeah, there, now we can see. Now we can't see the question. What is the risk associated with incorrectly inputting the patient position, like supine versus prone, for the localizer scan?
You're going to run the risk of imaging the wrong region of interest. You're going to have to do the scan twice because all your information is going to be wrong, so you're increasing radiation.
Of these choices up here, what are going to be, what's the correct answer of these choices? B. Yeah, B is the correct answer here. Cross-sectional images will be incorrectly marked, so like the right will be where the left is, or the ant will be the post is, something like that. And so we pose a real risk for example, if there's a lesion in the right kidney, they could say, oh, a lesion in the left kidney. Now they're biopsying the left kidney. It comes back negative. The patient's told they don't have cancer when really they do. All right, so this is a significant thing to consider. Okay, step and shoot scanning is what like the first generation scans could. This is solely all that they could do was step and shoot or axial scanning. So the early CT scanners were called CAT scans, computed axial tomography, right? So they would scan, the table would move, they would scan, the table would move. There's a bunch of different names for it. I typically call it axial. So again, the key aspects are the table moves, it remains stationary while the tube and the detector rotate around the gantry. There's a pause, and then they move again, right? And so with an early system that just had a single row of detectors, this could take a long time. Like for example, imaging of the CT brain could take upwards of 30 minutes on the first generation CT scanner that was created by EMI. Reconstruction of those images could take upwards of 8 hours, right? So they did not have the computer power, they did not have the hardware that we have now. So she mentions the length of time here. And the new scans that we have are much, much faster, and so we look, when we get to our activity looking at pitch, we'll get a very real feel for just how quickly this stuff can move now. And we'll also hopefully have an understanding for why there was such a push to be able to scan faster and faster and faster, like through the 1990s. That was the big motivation. People were not as interested in dose reduction, they were interested in scanning faster. Those tables have kind of switched now. So from the axial or a step and shoot scanning method, we're going to get this, looks like pepperoni slices, right? Like slices down the length of a sausage or something. Versus helical, I think about, looks like a honey baked ham, right? Where it's been spiral sliced, right? So, advantages. When we're using any of our phantoms for calibration image control, the step and shoot method is going to give us the most spatial resolution for phantom imaging. So for experimentation reasons, Axial is going to give us the most. We can make them contiguous or non-contiguous, and so that's a matter of, again, the pitch. If we're moving at the same degree that we're scanning, then we can make those slices more or less overlap with each other. And one way that Axial is still very, very helpful is when we're doing any kind of cine or dynamic CT imaging. Where this would be important is in the interventional suite. So if we are doing CT guided biopsy, CT guided drainage placement, we will do axial scanning of the same location over and over and over because we're trying to insert a needle into a very specific area. So we can pre-program it. I want to get 5 slices every time you scan. I want you to scan this small area. I don't want you to move the table because I'm sticking a needle in this patient and it's a sterile field, right? So Axial is very, very helpful, very, very powerful for if we're doing any kind of CT guided procedures. The disadvantages of it is it drastically increases examination time, and the interscan delay can cause for loss of contrast. And every now and then there can be slice misregistration if the patient moves, and in between the scans, then we might see the patient's chest up here in one slice and lower down in the next slice, right? It doesn't make any sense. It just looks like a skip, right? Like the CD is skipping. So here is these single detector. Most of what I just talked about related to single detector rows, like so the first generation, second generation CT scanners. As we start to transition in this discussion, we're going to talk more about multi-detector CT scanning, and that's going to be these third and fourth generation. Specifically, all scanners now are pretty much third generation scanners. So most of what we're going to talk about today is going to be MDCT, multi-detector CT scanning. This sometimes is abbreviated SDCT, single detector CT scanning. Pretty much all of these are now completely obsolete in America and most of the developed world because, again, the dose constraints and the image quality. Nevertheless, it's helpful to know these detector systems. So each detector element in a single row is going to be fairly wide in order to allow for increased movement of the table while it's scanning. And opening or closing the collimator is going to be what determines the thickness of the exposed area on the detector array. When we're calculating the area of a patient anatomy to be covered with a single detector row, we're going to multiply the slice increment by the number of slices acquired. And we'll look more carefully at that during the activity today. Here is a question kind of related to that. And again, we'll unpack this a little bit more for the activity, but an examination protocol of a chest calls for contiguous 4 millimeter slices to be taken from the level of the sternal notch to the lung base. 60 slices are planned. How much anatomy in the Z direction will be covered with the cross-sectional slices? So what I'm going to do is I'm going to multiply 60 slices by 4 millimeter slices, and I'll come up with, what is that?
240 millimeters.
240, right? Good. The formula is very, very similar for a multi-detector system, only now we have the addition of rows or banks of slices. So with a single detector array, I can only acquire one slice at a time. With the multi-detector, I can acquire upwards of, I think the most current one is 200 something. So it goes 64, 128, and then 2 times 128 is what, 256. So the new generation CT scanners are 256, and you can imagine your scan times are going to be much, much quicker with that versus a single detector array. So she mentions that they may contain 4 to 64 already. That's dated, so you can see we've had huge advances in the hardware and the way these things are constructed. And so slice thickness now is determined by a combination of the X-ray beam width and the detector configuration. So we can tell now we are going to collimate the beam, but in addition we're going to activate certain detector elements, right? Or deactivate certain detector elements. 99.9% of the time, if you're scanning with a 64-row slice scanner, you're going to be using all 64 rows, right? But you can make some changes if you want. So here is a number of different ways that might be considered, and we can see how the width of the collimated area impacts pixels, so it's going to impact resolution, right? This is one of the primary concerns of CT technology is how can I get the detail that I need to see without missing stuff? And it's not as though scanning small every single time is the best way to do it, right? We need to scan to an appropriate size for whatever anatomy or pathology we're trying to image. So for example, with a routine abdomen, we will scan at 5 millimeter slice increments. Because any pathology I'm trying to appreciate will probably be visualized in that 5 millimeter slice increment. If I were to scan at 0.625 millimeter, right, so significantly smaller than that, not only would I be generating way too much information, any pathology that might be seen in that might actually be lost to just the vast amount of information that's there. It would be very, very, if I'm looking for appendicitis, for instance, that's going to be much bigger than that. They would have to scan through like 50 images to visualize the entire appendicitis. Okay? So that's one example. I want to make sure that it's the correct size, right? There's a lot of those kinds of considerations. So as we get into protocols this summer, that's one of the things we're going to be thinking about. What's the anatomy I'm looking at, and what's the appropriate scan size to match the size of that anatomy? Okay? Coronary arteries, right? Do I want to scan coronary arteries at 5 millimeter slice increments? How big are coronary arteries? Little tiny things, right? So I'm going to use a smaller slice increment, right? And that's the name of the game. So but from a computer standpoint, the computer is not really thinking about all that. The computer is thinking about spatial resolution. How big is the pixel? How big is the matrix that's being generated out of this stuff? So as I open up my detector, what I'm doing is I'm increasing my pixel size, right? So the bigger the area I scan, the bigger the area of the pixel size. So we lose some detail to just the size of the pixels. The bigger the pixels, the less spatial resolution we'll have. Versus if I go really, really small with my pixels, I'm going to have very, very, very good spatial resolution. Okay? So there still are applications for axial scanning with a multi-detector array. And we may use these with, for example, routine brain studies if we need to tilt the gantry. We will almost, for nuke med and for radiation therapy applications, we will never scan axially. An axial scan is pretty much useless from the standpoint of treatment planning for radiation therapy, and an axial scan is not going to allow the PET CT scanner to run, what is that calculation it does off of the CT images? Are you familiar with that? It does some kind of statistical analysis of the CT images and uses that to understand the PET images. I don't fully understand it, but they would not be able to run that calculation off of axial information. So helical scanning, was introduced in the late 1980s, and I typically call it helical or volumetric scanning. Some of the texts will call it spiral scanning. But again, it's the honey-baked ham way of doing things. So it's continuously rotating the X-ray tube while the table moves. There's uninterrupted X-ray output, and there's uninterrupted table movement as we're moving. It's going to eliminate any kind of interscan delay. The big advantages is that it's going to help us optimize the use of any kind of iodinated contrast because it takes less time for us to scan with a helical. It's going to avoid any kind of respiratory misregistration. It reduces motion artifacts. It also provides us, she doesn't mention this in the textbook, but a significant thing is it provides us with a volumetric set of data. What does that mean? It means it gives us basically, like if you can imagine this being a volumetric set, I have everything that's in this bottle of water here. Anything I want to do with this bottle of water, I can. Versus something like this CD, I have just this CD, right? So if I'm talking about a slice, I just have this, right? If I'm talking about a volumetric data set, I have the entire volume, every which direction of it. And I can do any kind of modeling from that. So probably the future of CT, I think we've talked about this a little bit, is probably moving towards things like 3D printing and stuff like that, generating things like facial reconstruction models and hardware out of the CT data sets. So being able to harness this volumetric data set's significant for a lot of reasons. So some of the major improvements is, we mentioned this, that they developed a slip ring gantry, and this came out of NASA, right? More efficient tube cooling, because we're going to have the tube on the whole time. So we had to figure out ways to cool it, and that largely came with replacing the way the anode works. It's going to have a higher X-ray output, so it work with an increased MA. It can actually vary the MA as it's scanning, so it can turn it up if it's not getting enough information. It can turn it down if it's getting enough. And the software is really, really detailed with how it moves the patient in and out. So we want to be careful when we're moving the patients in and out. We want to know their weight, that they don't exceed the weight limit of the table. And we want to make sure that there's no clothing or anything that's interfering with the way the table moves. Because the scanner is very, very precisely calibrated for the way the table moves. So here again is that helical way of thinking about what the images are like. We're getting this continuous array of slices and then representing that in any which direction we want. So from this data set, from an axial data set, all I can do is look at those pictures axially. If I try to reconstruct them coronally or sagittally or in an oblique plane, I'm not going to be able to do that. It's going to have little hiccups in it. But with this volumetric data set, I can now reconstruct this to be coronal, sagittal, oblique, or even three-dimensional. So the statistical analysis methods that we're using now in CT and the stuff that's being developed, and one of the things I'm working on for this article I'm writing, is that we are going back to the initial statistical analysis that we tried to use initially with CT, and we're reviewing that. We did not have the computing power to initiate it in the 1970s. We have the computing power to do it now. And so it's going to start interpolating data in different ways. That can result in a number of things. Like, for example, the ways that we used to measure certain pathology, like lung nodules, is literally changing right now. Like, as we're talking, there are a lot of decisions being made about the way that we view this information. And that will probably be the case of CT for the rest of my life. Is it will continue to be one of the most rapidly changing, one of the most rapidly evolving fields, along with, I think, nuclear medicine and MRI. So as we angle the slices on this, so I mentioned one of the advantages of axial scanning is that we can angle the gantry. For example, for a routine brain, we can angle the gantry, and we are not asking the computer to do anything too crazy to get us information from that, right? Because it's still stepping and shooting at just an angle. If we angle this volumetric data set, it changes everything. right? It changes literally everything. Like if you can imagine that roll of spiral slice, if you tilt it on its side, a lot of the angulation and everything changes with it. So its ability to interpolate between different points is going to be lost. All right, let's talk a little bit about pitch. So pitch is a parameter that describes the CT table movement during the scan acquisition. And it's very commonly defined as the distance traveled as the CT scan per each 360-degree rotation of the CT tube. Table travel per 360-degree rotation of the tube. And we can divide that by the beam collimation width. So when the table feed and the beam collimation are identical, the pitch is 1. If the table feed is less than the beam collimation, the pitch will be less than 1, and we'll have overlap of our images because we're scanning over an area that we already scanned. So if we need really, really detailed information, we might do that. But typically we're working in pitches in the range of 1 to 1.5. The most common pitch ranges are between 1 and 1.5. When we're talking about it in single detector stuff, table speed will vary according to the slice thickness and the gantry rotation speed selected. So for example, if we had a 5 millimeter contiguous slice, the gantry rotation is 1 rotation per second. The pitch is set at 1, so the table must move 5 millimeters for every rotation of the tube. And this would vary depending on the slice width, right? So 10 millimeter slice width, 10 millimeter table movement, right? Anytime the table moves the distance that is equal to the slice thickness, the pitch is going to be 1. Let's think by comparison. If we have a slice thickness and we keep it at 5 millimeters, but the table moves up to 10 millimeters each time of tube rotation, we're going to have a pitch of 2. So we are going to see an interruption in some of the material that we're trying to see. We're not going to be able to interpolate the data as well. There's going to be some little hiccups in the values. So increasing the pitch will result in a larger area covered, and it will decrease the total acquisition time, right? Decreasing the pitch is going to slow down the table speed, and it will decrease the amount of anatomy covered. And it would also increase the acquisition time, right? So again, back in the day, we thought that if we could get scanners that were scanning faster, we would be reducing patient dose, right? So part of it wasn't just this kind of crazy gangbusters desire to just be able to scan faster and faster and faster. As you can see with the single detector array CT scanner, if I'm having to mess with the pitch, I'm also increasing patient dose because I'm increasing the amount of time that the tube is on, right? What we're finding now with the multi-detector things is that just because we can scan faster doesn't mean that we can drop patient dose. We still need to be able to adequately sample the area that the detector passes over. So anytime we're talking about pitch in multi-detector CT scanning, we kind of have to expand the way that we're talking about it. So we're still going to talk about being a relationship between slice thickness and table travel, but as I mentioned in multi-detector systems, collimation and slice thickness are no longer synonymous. So we can talk about beam pitch or table pitch. Typically what we talk about is beam pitch because it's what the physicists prefer, right? There may be some times that we need to calibrate according to table pitch, but for all of our purposes in this class, we will be talking about beam pitch. So beam width in a multi-detector system is determined by multiplying the number of slices by the thickness of the beam. So here's an example of the kind of problem that I'm talking about. So we have a 16 slice scanner, a 0.5 millimeter slice thickness, a table movement of 2 millimeters per rotation. What's the pitch? So I'm going to multiply 16 by 0.5. That gives me 8. It moves 12 I'm going to divide, what, 12 or 8 by 12? Let me see. 12 by 8, I'm sorry. 1.5. So this is a pitch of 1.5. It's within that kind of general diagnostic range. I know I just worked through that very quickly. I will give you a formula. We're going to work on this together, okay? So if we're talking about the area covered, the amount of anatomy visualized on a scan, we can think about that in terms of time, right? So pitch, total acquisition time, the rotation time. So 1 divided by the rotation time will give you the number of images, right? If I want to know the amount of distance that's covered by the CT scanner, again, I need my pitch, total acquisition time. I'm going to divide 1 by rotation time, and then slice thickness, and that will give me the amount of anatomy covered. So these formulas are very, very similar. The only thing I'm changing between the two formulas is I'm adding slice thickness if I want to know the amount of anatomy covered. Okay. Again, for MDCT, I'm going to need to account for the fact that it has a multi-detector array, so I'm going to multiply the slice thickness times the amount of slices in the detector, and that's going to give me, it's essentially the same formula, but I've just, the addition of this one step here, slice thicknesses times slices per rotation, to account for the fact that it's a multi-detector array. So in this example, we have a 20-second acquisition, 0.5 second rotation, 2.5 millimeter slice, 4 slices per rotation, a pitch of 1.2. So here's pitch times 20 seconds times 1 divided by 1/2, so that's 2. And I'm going to multiply these two things together because it's a multi-detector array CT scanner, right? So these are being considered as more or less a single thing. I'll multiply these together separately, and then I'll multiply the other stuff. That will give me the amount of distance covered by along the z-axis by the CT scanner. Okay. One of the nice things about having a volumetric data set is we can do a lot more things retrospectively. So they'll talk about retro recons or reformatting something after the fact. And we'll get more into like what those kinds of things look like at a later date. But we can create overlapping slices without increasing the radiation dose to the patient. We can just do it after the fact, right? So we can take this volumetric data set and create new data sets out of it that can increase resolution without increasing patient dose. The one problem about it is it can reduce the partial volume effect. Okay, and what that means is if we have a pixel that was not completely activated by photons and things like that, it may not fully register, and so we may wind up with some misrepresentations of data. Okay. A few more options that we have, and this is part of what we'll be unpacking as the class moves along, is that if we're going to if we scanned at thin slice, we can actually create thick slices from that data set, right? Every now and then, with certain CT systems, if we have a thick slice, we can reduce that down to some thinner slices. But generally that's going to cause us to lose some resolution. Now, dual source CT scans are kind of, they have some limited applications. This is CT scanning that has 2 tubes, and they're going to be at 90-degree angles to each other. So like this, more or less. You'd have a tube up here and a tube over here, and then I would have a detector array over here for this tube and a detector array over here for this tube. Okay? The advantages with this, of course, is we can scan even faster, right? But there's a lot of factors with this that can increase the complexity of the way that we're evaluating this information. And honestly, most of the dual source stuff that I've seen is still very much in development. If people are really interested in this, especially X-ray tech folks, if you're interested in this for a research project, this might be something of interest, okay?